welcome. We're happy and excited to welcome you to our May edition of our SIOP Global Health Network Nursing and Supportive Care Working Group meeting. It's an educational session. We are very excited this morning today to be able to introduce and welcome Dr. Justin Baker, who is the Director of the Quality of Life. I don't remember what the A stands for, Dr. Justin. Quality of Life.
Quality of life for all.
For all, the koala team at St. Jude Children's Research Hospital in Memphis in the United States. And he is going to be talking to us about the assessment and management of neuropathic pain. So a little bit separate from his typical topics of palliative pain control, but very specifically to neuropathic pain, which really affects all kids. So that's where the A does definitely come in from koala. So we just have one announcement. Hopefully everyone knows that registration for the SIOP Congress is now open. And so everyone get your registration. I think the early bird deadline is July 1st. We're excited to see everyone in person again this year, hopefully. So Justin, I'm going to turn it over to you. Thank you so much for joining us. And we're excited to hear from you.
Great, thank you so much.
Julia has raised her hand. Hang on,
Justin. This is so weird. Justin, is it possible for you to change good morning, first of all, is it possible for you to change your name in the window just in case somebody's missed your name and they come in a minute or two late? They might think you're Shanila.
Yes.
Because you don't have it on your slide and I don't want them to have dissonance.
Yes. Yeah, I like that. Yeah, here, we'll put it in. That's a good idea. I'm changing it right now. This probably will mess up Shanila for the future. So we'll see. Great. Well, friends, thank you so much. Are you able to see my slides okay?
Yes, we can see them.
Super. So I'm going to, oh, I just pulled out of that. That was not my best move there. I'm going to speak today on neuropathic pain, and it's better if we kind of can have a conversation if you want to stop me at some point or things like that. It's a little difficult for me to see the chat at the same time as I'm giving the talk. And so Liz, maybe you could help monitor that. And if something comes up, you can let me know.
Yep, no problem.
Great. So when we think about neuropathic pain, we're going to look at some tools for overcoming general symptom management barriers. We're going to appreciate the high prevalence of neuropathic pain. I'm going to define neuropathic pain and describe the main causes in pediatric patients. I'm going to talk about opioids as a first-line agent in neuropathic pain. And then we're actually going to spend the majority of our time in kind of developing a step-by-step treatment approach. And this treatment approach is very much, I'm just owning this, based on a US-based system of access to pharmacologic management. But I will also speak about non-pharmacologic agents, et cetera. And it's probably a little bit more of an aspirational talk for those of us that are working in resource-constrained settings. So I like to start everything out with the clinical cases always. And so let me start this way.
Evan, can we get you to raise your right leg using your foot like this? Yeah, it doesn't hurt until about here. Then it really hurts.
Okay, you can go ahead and put that down. How's the area around the dressing where we did the surgery and biopsy?
It's a little bit more achy than pain. When I move, why is my leg shaking? It never did that before the radiation and surgery. Let's get you to sit down right here, right there. There you go. The main nerve in your right leg had cancer growth around it. And so when we did the surgery, we tried to relieve some of the pressure around that nerve and get you back some control of your leg. Now, the shakiness, think of that sort of as a short circuit because of the cancer in the nerve tissue. Oh, well, that go away. My leg is moving better, but the shake and achiness, I can't really move that well with them both.
Well, we don't know if the tremor will go away entirely on its own, but there's a number of things we can try to help and reduce it and treat your achiness too.
Okay, so what then?
Well, you've got 3 pain symptoms happening at the same time. You have the bone.
Может да го оставиш...
which we believe is from the chemotherapy and then the tremor. some stretching and strength building in your leg will help with your achiness. So I think that PT might be a good option. You're out of surgery, doing well, recovering well. So I think we can go back to managing your bone pain, and hopefully that'll get you back under decent control.
As far as a tremor in your leg, there's a drug called phenytoin that we'd like to try. Now, in large doses, that works to help control spasticity and seizures. But in really small doses, it works really well on tremors like yours. Now, I can explain all of this to your mom when she's here, but we think we'll be able to get some good pain management for you and get you back home and back to school. That would be great, because I don't want to be here any longer. No offense to you two. No offense taken, Adam. We get you. Now, would you mind? I'd like to take a look at your surgery site. Can we get you back up on the bed?
So this is obviously why we do what we do. It's caring for patients like Adam. And if we really think about how specific we usually are in treatment of things like cancer or our very protocolized approach, we generally don't do that same approach towards or take a similar approach towards the management of symptoms. But most distressing symptoms in pediatrics can be managed in a stepwise fashion. Step 1, evaluation. Step 2, treating the underlying causes. Step 3, integrative and rehabilitative and supportive therapies. And step 4, pharmacologic management. And we usually just skip right over, at least I as a doctor, skip right over to pharmacologic management. And the reality is we need to be much more specific in our approaches. The other thing, though, that we have to realize, and I think this group is probably much better at understanding, is that there's like suffering comes in many different frameworks. And it's not just, Adam is not only suffering from the physical pain of his surgery or the tumor, but he has all of these other things that come in, these visible threats, the invisible threats, and these all contribute to suffering. And so when we think about suffering, it's very important. And I actually like to conceptualize this with people when we think about palliative care. As an oncologist, the enemy that I treat is cancer. As a palliative care physician, the enemy I treat is suffering. And so literally the disease entity that I am interested in addressing is suffering as a disease. And what that means is you have to look at all these different aspects. You have to think about disease management, physical aspects, psychological, social, spiritual, practical. End of life certainly is a part of it, but as you can see, that's only a part of things. And then obviously loss and grief, all of those in specific patient and family contexts. Cicely Saunders, over 50 years ago, described the concept of total pain. And I like to conceptualize this as the concept of total suffering. And to be able to treat that well, there's really some key tools. And these key tools in providing symptom management include these. Number 1, your ears. You have to listen, and you have to listen well. To listen is to continually give up all expectations and to give our attention completely and freshly to what is before us. Not really knowing what we will hear or what that will mean. In the practice of our days, to listen is to lean in softly with a willingness to be changed by what we hear. Now, this is pretty amazing because that means some of our greatest tools are simply right here. Certainly we need knowledge on how to go through these 4 steps, but so much of it is bearing witness. So much of it is providing this compassion, working with our heart, literally suffering with our patients and families, taking part of that weight upon them. And then third, we really have to think about this as a team. And you heard in Adam's case, physical therapy needed to be involved, certainly nursing, physicians, that was potentially a palliative care, an oncologist. So, I mean, there has to be a multidisciplinary approach. So we really need a team that's willing to fight with each other for the best possible outcome. And so there's 2 other concepts that we have to recognize as well. And I love that video because they're talking directly to Adam. We have to involve the children in this process. And that doesn't mean we treat them just as we would perhaps their parents. And I know there are cultural issues involved with this, but we need to help the children not feel alone and engage them and involve them in whatever way we possibly can. And the other piece is we have to realize that communication should be certainly culturally appropriate, honest, child-centered, and it needs to be timely. And so when we think about things, when we're asking about symptoms, we certainly need to ask the usual questions. Things like, quality, radiating, timing, alleviating, and aggravating factors. We need to ask, how is this symptom affecting their life? This is why communication is such a huge component of symptom management. What would they want to do differently if their symptom was better controlled? Ask and tell me more about that. We need to encourage talking by using active listening and silence and responding to emotions with nurse. And if you've never heard that before, that means the N of nurse is naming. This is really difficult. The U of nurse is understand. I can't even imagine what you're going through. The R of nurse is respect. You are such a strong advocate for your child. The S is support. We will support you no matter what. And the E is explore. Can you tell me more about what you're thinking? So we need to understand we need to respond to emotions, because sometimes that's what's really so contributing to that total suffering that we're talking about. Are people interested in trying something to improve the symptom? Meaning sometimes I had a patient who was really, really nauseated, but she was trying to write a book. And so the nausea medicines that we had, they caused her to be too tired. And she said, nope, I would rather have the nausea and write my book than be tired from it. Evaluate when necessary. We should think about looking at scans or labs if we can't figure this out. Please don't immediately brush off this symptom as expected or normal for cancer or cancer treatment. This can really send the message that there's nothing more to do about this. And please don't assume that just because you've kind of tried a lot of different things, that there's nothing more you can do, because there is always more we can do. We also need to remember that symptoms are still very, very bad, and they really drive quality of life. And you see here, pain. We're talking about neuropathic pain. Pain is the most prevalent symptom and distressing symptom that our patients suffer from. And you see here, this is over 60% of the time at the end of life. In the modern era, patients are suffering from pain. We've really got to do better. And it all starts with assessing symptoms. Assessing symptoms is critical. I love this study because in this particular study, the only difference between these two arms, there's a survival benefit in the arm where assessment of symptoms was done prospectively and with a patient-reported monitoring system. So if you are able to report patient-reported outcomes and you're able to bring symptoms into the ongoing aspect of your monitoring, you can literally improve survival, not only quality of life, but also survival. So now moving into pain. When we think about pain, as I just mentioned, the majority of children with advanced illness, more than 60%, say they significantly suffered from pain. Pain can be nociceptive, like somatic or visceral, psychosocial or spiritual, like I said, the total pain, and or neuropathic. There's also a new understanding of pain, and I'm not going to talk about that extensively here. It's called nociplastic pain, and that's actually where the treatments of pain are basically causing more pain. And so that's an interesting concept. When you talk about neuropathic pain, most of the neuropathic pain treatments are not going to cause nociplastic pain. There's really a call for action because we're just not doing a good job at treating pain. Neuropathic pain is not routinely assessed, and children are not effectively treated very often. And so when we define neuropathic pain, it's defined as pain arising as a direct consequence of a lesion or disease affecting the somatosensory system. But not all lesions in the somatosensory system lead to neuropathic pain. So it basically means there's some sort of nerve damage that is causing, or nerve-related damage that is causing this pain. I want to share with you another video at this time.
Thanks for waiting, Natalie and Rick. We got a good look at. Urgent care this morning. What happened yesterday? He was walking around just fine. This morning he can barely move his legs. He was almost screaming in pain when he woke up.
Great. I saw him on Tuesday. pain medication is taking care of
So
that.
we're looking at his MRI, we see a mass low on his spine, right on several of his lumbar vertebrae on the right side. Now, this is putting pressure on his spinal cord, and we're almost certain that this is what's causing the loss of motor control and feeling in his legs.
Our kid's already been through so much. Is there any chance of him getting feeling better?
Well, the metastases is pretty spread out in that area, so we think that targeted radiation directly on the mass is our best shot of reducing that pressure, relieving some of that pain and getting his feeling back. Surgery is not an option because, again, the metastases is so undefined. That's why we think targeted radiation is our best shot. Wow. When would you do this? Or right now? If we can get Adam prepped to schedule yet this morning, the sooner we attack this, the better shot of regaining feeling in his legs.
We have Adam in a room right by the ER right now, so we can get him scheduled and admitted as soon as you want to proceed.
I'm with you, whatever you want to do. You know,
Is this our only option? Right now, if we're talking about regaining mobility and sensation, yes, this is our only option.
how soon would you know if it was working?
Well, within a couple days, barring any complications, we'll take a look and see if there's any improvement, and we can have Adam home in 2 or 3 days. So you can go back to school and wait for the results if you like. We can also start him on some steroids to suppress some of the inflammation in his hip.
Well, I think we should talk to Adam, but it sounds like this is his only option for walking a little longer. I think we should try it.
I have Adam in a room, he's resting comfortably and he's very alert, so shall we go and talk to him right now?
Okay.
I'm sure that that really resonates with you all because this is the work we do. This happens here at St. Jude on at least a monthly basis where somebody comes in with such a distressing symptom as that, where it may have progressed from him having this neuropathic pain to now not having the strength. And so when we again think about the management of symptoms, we have to think about evaluation, treating the underlying causes, integrative and rehabilitative and supportive therapies, and pharmacologic management. And so the step-by-step approach to the management of neuropathic pain includes an evaluation. And realistically, that's the most important thing we can conceptualize is a history and clinical exam. We probably don't need lab tests, and then we have to contemplate, do we need a radiographic evaluation? And we may well. But again, when you think about pain, I want you to remember this iceberg. The tip of the iceberg can just be the actual pain that it's seeing. But look here, there can be psychological pain, anxiety, deconditioning, poor sleep, spiritual pain, withdrawal. I mean, there's so much that exists under the surface. And so we have to really be, again, as we're evaluating, recognizing what a huge issue all of those components can be. And so in assessing for neuropathic pain, there's actually no validated neuropathic pain scales for children. There are adult scales, such as the neuropathic pain scale, which is a 12-item scale, or the pain quality assessment scale, which is 20 items. But what we have to do is we have to evaluate for paroxysmal pain and paresthetic or dysesthetic pain, which takes us, like, when we're doing a pain assessment, we need to understand from them kind of what that pain feels like. And you'll see on my next slide as we kind of talk about that assessment. And so when we're talking about, again, pain, we should mostly just be using a traditional pain scale, which could be FACES, the FACES scale, or FLAC, cries, or comfort. These are all specific pain scales. In older children, we almost always use a numeric rating scale. And then we think about the descriptions. So the descriptions might include things like numbness or tingling, certainly burning or electric-like, shooting or raw skin, or somebody might say something like it feels asleep. So it might not be actual something that you would consider as pain, but it's, instead of tingling, sometimes people use the phrase feels like it's asleep. And we really also have to assess for something like allodynia, which is pain from a stimulus that would not usually evoke pain. And a way to do that is with light touch. Very light touch can cause this allodynia. And allodynia certainly can be a type of neuropathic pain. but it also could be an example of when there is hyperalgesia. And this is an exaggerated response to a normal painful stimulus that can be part of this thing that I talked about of nosoplastic pain. Allodynia and hyperalgesia can actually be signs of opioid toxicity. This is fairly recent. I used to, and opioids don't have a ceiling. Like you can keep going up on the opioids, but if you're having to keep going up and the pain's not getting much better, it may well be that the opioids are actually contributing to some of that pain. And that's a fairly new concept that we're just beginning to learn more about. Now, I'll tell you, not all kids will just say, you know, here is where I'm at on the FACES pain scale. So we need to be, you know, creative. And so we might want to ask simply, how do you rate the burning pain in your feet? Or on a scale of 0 to 10, how's your constant pain in your back? Or how much does your heart hurt if it happens to be some sort of deep chest pain? And then, I mean, I have these koala bears, and maybe we ask the koala to help us for little younger kids. But the point of the matter is we need to make sure we have a good assessment and a good understanding. And now the very interesting piece that we have to understand is children certainly, almost definitively, and quite regularly experience multiple types of pain. Could be nociceptive, where there's actual tissue damage, as I mentioned earlier, somatic or visceral pain. Could be the total pain concept of psychosocial or spiritual pain, and or neuropathic pain. And frequently, especially at the end of life, it is all of the above. It is every aspect of this. So when we start thinking about the spectrum of pain management, we certainly want to start at the least invasive and then move towards the more invasive or most invasive. And when we think about that, the least invasive interventions are going to be things like integrative and rehabilitative or non-pharmacologic approaches. Then we might think about topical medications, pharmacologic therapies, and then interventional strategies. So this is important to just kind of set the stage as we move forward, because as we think about these aspects, we have to realize that as we're looking at things like treating the underlying cause, we want to also think about what's the least invasive to the most invasive. So as I mentioned, step 1 is evaluation. Step 2 is treating the underlying cause. Now, a key, and we're going to talk about this at the very end, we need to think about what are the overall goals of care. So you heard that a little bit in Adam's case. And so Adam had likely incurable disease, but one of his goals of care was being at school. You could hear them talking about he could get back to school, and being at school with new inability to walk is very complicated. And so obviously there are some situations where a family may say, I just want to be at home as much as possible, where perhaps doing a course of radiation may not be within the context of the goals of care. But if we're treating the underlying causes, we need to, again, think about palliative CNS emergencies like Adam's that he just described, and thinking about radiation or glucocorticosteroids like dexamethasone that they referenced there, and surgery. Sometimes surgery can be quite helpful in these situations. So we have to think about things like spinal cord injury, tumor, that as far as the potential causes of neuropathic pain, could be spinal cord injury, could be tumor related. It's quite frequent we see phantom limb pain. So this is again after a amputation where pain is felt where there is no longer a limb. It could be autoimmune or metabolic issues or neurodegenerative issues, but it's very common that we cause this with chemotherapy, things like vincristine or cisplatin. And what we have to also realize is that a very helpful potential intervention in the context of some of those issues is radiation therapy. And that's why I included the story of Adam in this particular case. And the indications for radiotherapy, it all depends on where we are with our goals of care. Could be pain, could be loss of function. It could be issues related to trying to prevent spinal cord compression. But a key piece, and I found this to be true in pediatrics, is that the goal of radiation therapy, even if it's done in the context of palliative radiation, meaning it is not curative, it's not always well understood by families. And so it really does come back to those issues related to communication. All right, so again, the first step is evaluation. The second step is treat the underlying causes. The third step is integrative and rehabilitative and supportive therapies. And when you think about integrative pain management, state-of-the-art pain management in the 21st century, it demands that pharmacological management must be combined with supportive and integrative or non-pharmacological therapies to manage a child's pain. And this has to be more than, as you can see in this cartoon, I'm too stressed, too nervous, too rushed. I need peace in my life. I need calm. You should try meditation. It didn't work. So no, we have to give this a little bit of time. We have to allow for an opportunity for patients to have things like distraction that can really be so helpful. These are an expected part of a pain treatment protocol or approach. And so this might be things like TENS or comfort positioning or allowing for the family to be close and in contact, holding the child. Rehabilitation therapies such as physical therapy, as we heard with Adam, or occupational therapy. It might be behavioral, which could be taught by any number of members of the team. Certainly our team can teach things like deep breathing and imagery. People trained in hypnosis, such as our psychology team, can help train in self-hypnosis. And then there's a lot of apps that can be used. There's things like balloonimals. If you look up balloon animals, you'll see how that can help with both deep breathing and distraction. And then there might be things like acupressure, acupuncture, and aromatherapy as well. When you think about these by age, in infants, you're mostly thinking about positioning, things like swaddling, hugging, holding, and then sucking, things like breastfeeding, sucrose, or pacifier. These can be very relaxing. In young children, again, we might think about hugging and holding, but distraction is a huge deal. What can we do to distract? We actually just got a new Oculus, and we now have this that we were testing out yesterday. These are one of those virtual realities. And so virtual reality might be something you could use, or therapeutic activities like play, art, and music. And then also animal therapy. In fact, in many cases, animals are some of the very best distractions that we have. We have wonderful dog therapy here at St. Jude that's so helpful. And then there are obviously in older children, it really depends on what works best for them. And I have a list here, but it might be psychological preparation or hypnosis, certainly can be biofeedback and acupuncture and acupressure. And then we can also think about massage really at any age. And that's tremendously helpful, massage. And we actually have an entire massage program here at St. Jude. Another component that I really want to speak about at this point. And so when we're thinking about integrative and rehabilitative, we need to contemplate activating the entire multidisciplinary team. This is not a one person show. We have to make sure that we're addressing all these different angles of suffering. And when I think about this, I think about family support, education, supportive counseling, parental guidance. You saw Adam's parents and how they were like so anxious. So we have to think about, I mean, does a family need respite care? Certainly there's all these comorbidities that happen. And when everybody's so anxious, that makes pain worse. Pain is absolutely impacted by other symptoms. And so we have to think about other comorbidities. And one of those might be school absenteeism or other activities like that. And I wrote here, if you're truly a team, show me your scars. I had that on the other slide as well. And what that means is every team member should be willing to go to battle for what they believe in, for their particular aspect of what they're fighting for their patient. And what we need to do is we all need to be working with these patients and families, and that might happen individually, but then we come together with an interdisciplinary care team meeting, and then we show a unified front to the family in a family care conference, as was demonstrated really in that setting with Adam. You need to figure out who are the right people to have these conversations. These can be difficult conversations if they're acute issues moving forward, or if there's shifting goals of care, for instance. And so we really have to make sure that we're providing a multidisciplinary approach to pain and symptom management. Okay, we're going to get into the pharmacologic toolbox at this point, and this I mostly want to provide this to you all in this particular setting, in this amazing working group here, mostly as a guide so that you can understand some of the high level concepts. I'm not going to provide dosing. I'm not going to provide things like that, because I just want you to have these in your mind so that you can help make recommendations. You can bring things up when we are in this interdisciplinary care team meeting. We should certainly hear from you all about about things that we're teaching today, about aspects, even if they're pharmacologic, that might be helpful for patients like Adam. So as we conceptualize these, we have to realize that in the context of neuropathic pain, and really just pain in general, there are main aspects and areas where drugs work, and they're in the brain, in the spinal cord, and specifically in the dorsal horn. And then there's even peripheral sensitization. And so when we think about these things, there's descending inhibition, and these are the categories that work as we're thinking about decreasing or inhibiting flow of these sensations. There's central sensitization, which means your brain, as you get more and more pain stimulus, you actually get sensitized, as we have to deal with that. There's issues at the peripheral nervous system that we have to be thinking about. And so these are the categories and where they work, each of them there. And so when we first start out, it's really important to realize that with basic analgesia and opioids, we can treat the majority of pain. So about 85 to 90% using the WHO two-step approach of acetaminophen and NSAIDs, as well as opioids, can treat general pain. It's the same thing for acute onset neuropathic pain. So again, I'm not talking about chronic pain or a primary pain disorder. In fact, if you're talking about chronic pain, which can include what seems like neuropathic pain as a component, in chronic pain, almost always opioids are not only not indicated, they are harmful. But in acute onset neuropathic pain, in the context of cancer that all of us are dealing with, and that's how it usually works, opioids can be helpful for new onset. I'm going to teach you something that actually is, I remember when I first learned this or heard this phrase, it was almost 20 years ago now, and I just will never forget it. But I love this because I've actually found some ways to cite it. A principle of pharmacokinetics teaches us that unless the drug reaches the site of action, it cannot be expected to exert its dynamic effect. In fact, if you are dealing with a patient who's in pain, and this patient is likely to be in pain later today and even tomorrow, please realize that the PRN certainly does not mean this in Latin, but in your mind should mean patient receives nothing, because they have to ask for it, and they're not going to ask for it until they're in pain. And our whole point of treating pain is trying to prevent pain. So with morphine, the situation is that when the drug does not reach the patient, what hope is there for pain relief, right? How true is that? So if you see an order written, and this is actually very common, that people will not provide a scheduled dosing of opioids, they'll simply provide a PRN dose or even somewhat regular PRN dosing, and not really think about that a patient always has to like be woken up or they wake themselves up, or their pain wakes them up in the middle of the night and then they have to ask for it. That it just doesn't make much sense. So I really like this slide, and I hope you'll remember this, that PRN means patient receives nothing. So now after we get through basic analgesia and opioids, step 2 of neuropathic pain management is the gabapentinoids. And I'm telling you, gabapentin is like, it's amazing how well this works. This works in so many different settings. Another medication we have here is pregabalin. And pregabalin works very similarly. For us, if the gabapentin doesn't quite seem to be working in the way that we had hoped, we might switch to pregabalin, but it's not common that we use it, probably only 5% of the time. The main side effect is sedation, so we start low and titrate up. We'll have this recording will be available so people can come back to this, but again, I'm not going to cover, I had the doses on these slides, but we're not going to cover these today. The main mechanism of action is that it's a calcium channel blocker. It actually decreases the release of pain transmitters. And in pediatrics, pregabalin is still not an actual there's not an indication for pediatrics. One of the things that I did, I told you before that a side effect is certainly sedation. That's the main one. There are additional side effects such as nystagmus or just a little bit of a thinking issues, headache, these are rare. I'm telling you, I use gabapentin almost every day, and by far the most common side effect is being tired. Okay, again, so now we have basic analgesia and opioids and gabapentinoids. After that, there's a little bit of debate over what the next best medicine would be to potentially try. And I'm going to tell you what we do here, and then we'll just, you can tell me if that's what you do where you're at or whatever. But I'm talking, so I get to tell you what we do here. So we'd start with gabapentinoids, and then next we would layer on a tricyclic antidepressant. And most commonly for us, we use amitriptyline. And it's great because it's so common that patients like Adam actually very frequently also have sleep problems. So here now, with adding a tricyclic antidepressant, amitriptyline has very predictable sedation. And that sedation really, it doesn't really wear off that much. It does get better with time, but if you give amitriptyline at night, they will get tired and they probably will sleep better. Better sleep certainly also helps with treating neuropathic pain. There's symptom clusters, and so sleep is and sleep disturbance is a part of almost all the symptom clusters. And the hard part is poor sleep leads to worsening of almost all other symptoms. And it's something that realistically, again, in the hospital, we're terrible about. Like, we just wake people up all the time thinking this has no impact. It has tremendous impact, and we just are not very good at realizing the negative impact of us interrupting sleep. So when you think about the side effects of the tricyclic antidepressants, again, it's a predictable sedation, which is actually what, in my opinion, is helpful a lot of the time. It can be anticholinergic. There certainly can be dry mouth, and then prolonged QTC can also happen. And so in the United States, we have a variety of options. But the one by far that we use the most is amitriptyline. Now, people frequently ask us other antidepressants, and there's just not quite as much information about those. But if you, again, a common component of a symptom cluster is depressed mood and potentially generalized depression. And so you might want to think about starting an SSRI or an SNRI. And the reality is these may help contribute to the treatment of neuropathic pain, but they've not been proven very well independently to help. So it's also incredibly common that we have both tricyclic antidepressants and gabapentinoids together. And as I mentioned, some people would start with tricyclic antidepressants and then add a gabapentinoid. We here start with gabapentinoids and then the other, but you really can't, you can't go wrong if you were to flip back and forth. And combination is really recommended. And again, many, if not most, and as I'm trying to think about it, probably about half of our patients are on both of these if they have neuropathic pain. And so that, I think that's helpful to know that. Neonates, really, gabapentin is the only thing that we use. We would not usually do amitriptyline in neonates. So again, now we've got basic analgesia and opioids, gabapentinoids, tricyclic antidepressants, and then NMDA receptor channel blockers. This is really very important. In the concept of this nosoplastic issue that we're not talking about a lot today, that is felt to be regulated actually through the NMDA receptor. And so if we're able to block that, it actually helps with everything. It helps the treatment of neuropathic pain. It helps treat hyperalgesia and allodynia from basically opioid toxicity. And so the two main medicines we use are methadone and low-dose ketamine. And so I'm going to walk through both of those just a little bit. And realistically, at this point, people that are not really comfortable treating pain, like I feel like up until this point, this could be a general pediatrician or otherwise. But once you're getting into methadone and ketamine, it's probably better to have a pain specialist or somebody that has some expertise in pain, or a palliative care physician helping at this point. Again, ketamine is an NMDA receptor antagonist. It inhibits the pain wind-up phenomenon, which is what I just talked to you about. It reduces opioid tolerance and opioid-induced hyperalgesia. Something that not many people know is that if you have ketamine going, even low-dose ketamine, you actually may be able to decrease the opioid consumption. We just had a conversation about this on our listserv, and kind of the general practice is when you start ketamine, you actually decrease the opioids by about 20%, even as you get started. There is oral dosing available, and there are oral dosing protocols. And so a lot of times people say, well, we can't use ketamine because it's so hard to use on the floor. You actually can just have people take it orally. And even though it takes a little bit longer to kick in, by day 2, it's very common that people are feeling much better. I'm going to linger a little bit on methadone because methadone is amazing. And once I started really becoming comfortable in using methadone, it has completely changed the way that I practice. And methadone has 3 main mechanisms of action. It's an opioid receptor agonist, meaning it actually treats pain. It is an NMDA channel antagonist, means it actually helps itself treat pain better and blocks the side effects, the bad side effects of the pain medicines. And it actually is a presynaptic blocker of serotonin and norepinephrine reuptake. And so it actually works a little bit like an SSRI and an SNRI together. So it actually can help with issues related to the psychological and psychiatric components of pain. It has a very long half-life. And so this half-life of methadone, the problem is you can get a treatment effect quite quickly. You usually will feel the effect of methadone within 30 minutes, but then you have a stacked effect later also, and steady state of methadone is not really achieved for about 3 days. And so you have to really be slow in adjusting methadone. And again, sometimes that makes people be worried. And so I'm gonna tell you some of the advantages and some of the disadvantages, and then I'm gonna tell you how we actually use it here, in which case I think it's pretty effective. So the advantages, super long acting. It helps an incredible amount with advanced cancer pain because it deals with neuropathic pain and nociceptive pain and touches a little bit on that concept of total pain. There's less tolerance, meaning you don't have an increasing dose of opioid that's consistently needed because methadone helps block the NMDA channel block. It functions as an NMDA channel blocker. It is actually a rapid onset of action. People don't know that, but when you take the dose, you get quick response to that medication. But as you'll see in the downsides and the disadvantages, people, because as soon as they see that nice quick effect, they think, oh, let's just give more of that. They don't realize how long the half-life is. It doesn't have active metabolites, meaning it's safe in renal failure and it's stable in liver disease. It has incomplete cross tolerance. And so what that means is, I'll tell you in a minute how we use it, but we don't usually convert straight from morphine to methadone. But if we did, we wouldn't have to decrease the dose. And then it's inexpensive. And that's a huge plus. And it's actually fairly widely available. So some of the disadvantages are there's a lot of dosing variation. And it's huge half-life. I told you that. Equal analgesia conversion is actually pretty complex. So that's why I'm going to tell you how we do things. There can be sedation and prolonged QTC. And so actually when we're using it when a patient is receiving active chemotherapy, we do recommend getting an EKG only because perhaps that patient then is getting other medications to help treat their cancer, to treat the cancer that may be QTC prolonging as well. And then there certainly could be stigma. And here in the United States, methadone is used as part of kind of a heroin treatment centers. And so that there can be stigma related to that. And so because of this, it's difficult to dose. It requires careful attention. It's metabolized through the cytochrome P450 system. And so we have to watch that. It increases QTC. So because of that, what we do is we use low dose layering. And this is the one time I'm going to tell you about a dose today, and I'm going to make some recommendations to you, just so you can take this back to your hospital systems. So when somebody is full adult size, we might, or like a teenager, we might consider using 5 milligrams twice a day or 3 times a day. And so that's pretty low dose. And so simply starting 5 milligrams twice a day, you'll see a profound impact. Or in smaller children, so let's say kids that are up to about 20 or 25 kilograms, we might use 2.5 milligrams twice a day. And then even smaller ones, we might even go down to 1 or 1.5 milligram 2 or 3 times a day. But we add that to their regimen. So we're not trying to change anything. We're just adding that, realizing there's going to be a real nice synergistic effect. And then as time goes by, we decrease other medications. We keep the methadone on. And as their pain gets better, we start taking away other opioids. That's what I mean by this low layering effect. Okay, so now we've talked about basic analgesia and opioids, gabapentinoids, tricyclic antidepressants. We've talked about ketamine and methadone, which are NMDA receptor channel blockers. I'm going to talk briefly here about alpha-2 adrenergic agents. And these are also tremendously helpful, but again, should not be used in the context of, I mean, they need advanced training to be using these. We have started using dexmedetomidine much more in our patients as they're approaching end of life. It has been a game changer. It has completely helped us tremendously. So both of these agents actually reduce central sympathetic output. And by doing that, this actually leads to analgesia. It helps with anxiolytic, it provides an anxiolytic effect. There's also sedation effects, but it doesn't usually cause respiratory depression. Clonidine, actually, there's a patch for it. It can be given a variety of ways. Dexmedetomidine has to be given as a continuous IV infusion. As we get to the end of this talk, I'm going to talk to you a little bit about palliative sedation therapy. And we actually use dexmedetomidine in a low dose infusion for all of our highly symptomatic patients as they're approaching end of life. And I'll explain that a little bit more in just a minute. Next, we might think about sodium channel blockers. And this is something we actually might have started earlier on, depending on where the pain is at. And these are things like lidocaine that could be done in a patch. Or if we're going to give lidocaine IV, that usually is because other things are just not working. And we want to think about almost like resetting the system. And so it's really important to conceptualize these issues. A transdermal lidocaine patch is something that we might use for what feels like a little bit of a superficial neuropathic pain. And in that case, we would have used it much earlier. We would have used it right along with those basic analgesia and opioids. But in the concept of IV, we really are going to try a lot of these issues. And then we're going to feel like, gosh, why is nothing working? And we kind of conceptualize this here, and we have to admit this patient for close monitoring when we do this to kind of think about a reset of the system. And then the other part that I want to always make sure we're thinking about, and this again is not at this point in our algorithm, we should have really thought about this a little bit earlier if there's some specific regional analgesia and anesthesia impact. So things like maybe an epidural, like a tunneled catheter, or a peripheral or a plexus nervous block, or a neurolytic block, or even an intrathecal pump or port. And when you think about these things, actually, these epidural catheters or intraspinal catheters or even peripheral nerve blocks, we might think, oh, those couldn't be done in the home setting, but we demonstrated actually here through a study that we did that actually at the end of life, partnering with hospice, and this was even when we didn't have a very good hospice, these regional anesthetic techniques, they certainly improved pain control. There were very few complications. Patients could still die at their desired location of death. And we were able to use them even though there were contraindications such as neutropenia or thrombocytopenia. We were still able in those situations to place these blocks to help these kids achieve good pain control. And then there's a variety of other things that we might consider in the context of other adjuvants. And those might include things like, again, we're thinking about how symptom clusters come and we think about all the different angles of those symptom clusters, but also total pain. And so we might think about things like benzodiazepines or muscle relaxants, antispasmodics. Topical capsaicin can be used a little bit like those topical lidocaine patches. Cannabis, certainly in some settings, people may advise this. We here in Tennessee, this is actually illegal for us to use in Tennessee. Bisphosphonates can be tremendously helpful for bony pain, and bony pain very frequently has a neuropathic component to it. Palliative chemotherapy. A lot of times we think of chemotherapy as perhaps the enemy as the disease is progressing, that chemotherapy is not really helpful. It's actually causing more harm than good. But the reality is a lot of times, especially if a tumor continues to be chemosensitive, palliative chemotherapy can be great for pain management. And then there's radiopharmaceuticals like samarium, which actually works almost like a targeted radiotherapy. So finally, as we begin to wrap things up, I also want to talk a little bit about palliative sedation therapy. And palliative sedation therapy is for intractable pain or other symptom-related suffering at the end of life. We use either propofol, well, we use propofol here, but then we also layer in dexmedetomidine, and I'm going to talk a little bit about our approach. Palliative sedation therapy, by definition, is the use of sedative medications to reduce patient consciousness. It's reserved for terminally ill patients that are at the end of life and have intolerable symptoms that are refractory. And I want to come to something I alluded to earlier, which is that in the context of the goals of care of pediatric oncology, there's a goal of cure, a goal of leaving no stone unturned, meaning we're trying our very best to do whatever we might do to convince ourselves that maybe we should be in a goal of cure. Maybe then there's a goal that comes next of live as long as possible and as well as possible. And then at the end, really not really focusing at all on the actual treatment of the cancer. And that is where we focus on living as well as possible and a primary goal of comfort. And certainly these are all evolving and changing, and they're all supported by hope. But what we have to realize is that palliative sedation therapy is really when we're in a primary goal of comfort. And the purpose is to relieve suffering and improve comfort. It's not really a goal of improving function or a preservation of consciousness. And the medications are titrated to the minimum reduction of consciousness necessary, but we sometimes have to rapidly increase those to alleviate suffering. And so when we think about the timing of this, and we've created an algorithm, we have to really realize that the first thing of palliative sedation therapy is to make sure that we've done everything we can from all the different angles, all the different people, that we've provided an exhaustive effort to treat this symptom in an appropriate way. And it's really important to have an algorithm in place. And what we've come to realize is that by creating a policy, it's really helpful. And every time that we are thinking about palliative sedation therapy, we include palliative care, we include ethics, and we include our pain team or anesthesia. And we all weigh in. We have an interdisciplinary care team meeting, and we all weigh in on kind of where things are at. And I think one of the things that we have to realize is that palliative sedation therapy is very uncommon. Only about 2% of inpatient deaths need palliative sedation therapy, or it was when we used it. It's more common if you start calling palliative sedation therapy, including dexmedetomidine. We use low-dose dexmedetomidine right now before going to propofol, and that's changed everything for us. We actually have almost never had to use propofol with the true palliative sedation therapy to the point of unconsciousness. We really very rarely use that now because of being able to use Precedex on the floor. And the clinical staff, we have to realize this is really a highly distressing situation because it's rare that we use it, and patients usually are highly symptomatic. There's a lot of moral distress around this. And so we always recommend a staff debriefing after using palliative sedation therapy to the point of unconsciousness. So as we close, I really want you to recognize that pediatric multimodal analgesia involves certainly basic analgesics, but it's so much more than that. We have to be thinking about adjuvants and integrative therapies and rehabilitation and opioids. We have to be thinking about spirituality, child life, and normalizing life, and regional analgesia and anesthesia. And then we have to, again, activate the multidisciplinary team. And so I want to leave you with this and just tell you that the main issue with excellent pain management is, frankly, people being concerned that there's not anything else that we can do. And the reality is, and I feel like a huge job, and hopefully what you're taking home from this is each of us can do something else. All of us can provide some layer and level of intervention that should be able to help alleviate, at least in part, some of that pain. And if pain continues to be an issue, keep advocating for that patient. Keep bringing people around until somehow we make progress to where that patient's pain is being properly addressed. I'm going to stop sharing at this point, and we have about 4 or 5 minutes for any questions that you may have. So thank you again so much for this opportunity.
Thank you, Dr. Justin. In the chat, we have one question. Is there a role of the vaccine in the pediatric management?
Yeah, it's very hard to hear you, Liz, but I'll answer both of the questions here in the chat, and then we'll go from there. So the buzzy, that's interesting because yes, the buzzy basically does cause this kind of tingling sensation, but the buzzy, for people that don't know what the buzzy is, it actually is something that we might use before doing a needle stick. It almost kind of causes people to have, it's almost like a distraction technique and kind of confuses the nervous system. And so you hopefully don't then feel the needle stick. So yes, oh, you're saying actually, I'm so sorry, you said use the word buzzy. Yes, so I just described the buzzy as a technique, which is a vibratory technique for placing IVs. But yes, they do sometimes use the word buzzy as an expression of feeling tingly. Duloxetine, yes, so duloxetine is a SNRI drug, and we addressed that a little bit, and this is actually the one, this in the United States is called Cymbalta. It's the most common one we would use, again, in the context of treating patients who have the symptom cluster of depression, neuropathic pain, anxiety. We would then probably go pretty quickly to duloxetine. So that is a great question. Mariana, thank you so much. Is there a role for dexmedetomidine? Yes, so, and I will tell you the dose that we use too. So in home terminal care, this is a great question. I'll tell you my answer to that is I feel very confident that if we would start dexmedetomidine in our hospital, that our hospice here in town would carry it out. The issue that ends up happening is patients are so close to their end of life when we start dexmedetomidine, meaning they may only have 1, 2, or 3 days, that for us, we've not done it in the home setting. We start very low dose, so we start 0.2 micrograms per kilo per minute on that. So 0.2 is our starting dose, Mariana, and we've gone up as high as 2.5. And historically, we were told this had to be done in the ICU, but when we have a do not attempt resuscitation order in place, we actually can do it on the floor. And so I think actually it certainly could be done in the home setting, and we'd be happy to share with you. We're writing a paper on this right now, and we'd be happy to share that with you and kind of partner and help support you if that's of interest to you. I think it has been a great medication and has helped us tremendously in not having to get to the point of using propofol, for instance, for deep sedation or full sedation to the point of unconsciousness. Great.
Yeah.
Yeah, thank you all so much. I'm so sorry, but I have a 9 o'clock meeting I'm going to have to jump over to, but I really appreciate the opportunity and thank you all so much. I'm happy to share any materials with you. My email, I'm going to put it here in the text or and you can email me and I'm happy to share anything with you that we have. So thank you so much. Bye, guys.